So your presenting patient, what are they going to look like when they come to you? One of them, they might be wearing bulky clothes. I can tell you, I have these tiny little stick girls who wear these extra large t-shirts. And even in the middle of July, they've got on hoodies, right? For two reasons. One, because when you're underweight, you're really cold. And so they're legitimately cold. And for another thing, they're so ashamed of their bodies, they want to cover them up. So I actually, all my shapes and sizes of patients tend to wear lots and lots of layers, even, and y'all know it's hot in San Antonio, right? So that's something you want to ask. If you see people wearing, big bulky clothes, ask. Another reason, they might have scars that they're hiding from cutting, and so that's something we haven't touched on a lot, but that's definitely something that overlaps with this population, particularly the young ones, a lot. So you just want to dig into what's up with the hoodie in July, right? They're probably anxious or depressed. So we talked about self-injury. They may be really hesitant for you to weigh them or to be asked about their weight. I will tell you, as a clinician, if you have a concern, if you have access to a scale, weigh your patients every week when they come in, monitor their weight, and you figure it out. If it's more than, our dietitian says if it's more than a 2-pound trend for 2 weeks, so if 2 weeks in a row they're up 2 pounds each week, does that make sense? Or down 2 pounds each week for 2 weeks in a row, then we're gonna ask questions about it because they're doing something. That's not normal, right? So, feel free to do that. A little hint, weigh them backwards, right? Because we don't want them seeing their weight, even though a lot of them are going home and they're obsessively weighing themselves 5-6 times a day. Some people aren't, and we don't want to do that, right? So you want to make sure that you're weighing them backwards on the scale so that they can't see their weight. They may have low body temperature, which also leads to a cold intolerance, dizziness. There's lots of reasons for the dizziness. It can be because of anemia from not getting enough iron. It can be because of restricting fluids, so they're what we call orthostatic, their vitals are off. It can be because of just weakness from not having eaten. There's a lot of different reasons that someone could be dizzy. Another note, someone could be extremely overweight and still be dizzy, still be anemic, have these issues. A lot of my binge eaters only eat like real starchy carbs and stuff. And so they don't ever eat vegetables, they don't ever eat meat. And so they're actually very malnourished. Even though they might be extremely overweight, they're very malnourished. So I have a client who actually was eating a box of macaroni and cheese for dinner and half a box for lunch every day for like 6 months. So there's just not a lot of nutrients in that. So she had a lot of problems. Hair loss, we talked about that, is something, if they report that their hair is thinning, you can dig into that. That's something they might actually share before they share other things. Receding gums, if they're swollen around here, and we talked about that, you may or may not see that really. Lanugo is the tiny little hairs that develop on your body as a way to keep you warm and protect the skin. Babies have it. If you think about the sheer tiny layer that babies are born with, typically people have to be fairly underweight, so you would probably notice that they're underweight before you'd notice the lanugo kind of thing, but who knows? So that might, if you notice these fine little baby hairs all over somebody, then obviously we've got a problem. Dry skin, a lack of menses, that is just not normal, y'all. People need to be having a period each month. That is a normal part of life, and if somebody's 17, 18 years old and they haven't started yet, I've had mothers argue with me and say, no, everybody in my family, everybody's different, everybody starts late, and you know what? I'm still digging into it, right? I'm still gonna get to the bottom of exactly why. And we're gonna make sure your daughter is a normal weight and that she, every other thing, and then whatever happens, right? But we're gonna take that as a huge warning sign. And then a lack of energy too. If they're just tired, if they say, I'll have patients who were obsessive exercisers and they come in and they're like, no, I haven't worked out in a few months because they just don't even have the energy, then that's a problem too, right? Okay, so let's talk about treatment. Let's talk about what treatment looks like. APA really says you need a multidisciplinary team, and that includes a dietitian, a physician, and typically an individual and a family therapist, kind of depending on the person's situation. You really need to be the dietitian, man, is just so critical. There is just no way someone can recover from an eating disorder without being on a meal plan and getting back to a normal kind of structure. I always say it's, you can't do like the Diet Coke of recovery. You can't have, I'm still going to keep the behaviors and I'm not going to eat as much or whatever, but I'm going to get rid of the thoughts. It's just not going to work. It's an all or none sort of deal. So the dietitian is critical. You might need a psychiatrist, right? There's a lot of medications out there. You want to treat the anxiety, the depression. There's actually some medications out there now, like Vyvanse is an ADHD medication that's been found to reduce urges to purge and urges to binge. And there's actually a few medications like that. So there's some options out there that can truly help with some of these symptoms. So you always want to do a psychiatric referral. When we talk about the levels of care, I'm sure most of you guys are familiar. We have residential care, which is where people are there for typically 30 to 60 days. You have acute inpatient, which is, they're there for like a week sort of thing. It's a stabilization. Typically that's for suicidality, or from a medical standpoint, it might be like somebody's severely dehydrated, they need an IV, that sort of thing. And then you have PHP, or partial hospitalization, which is an extended day treatment program. Our partial hospitalization program is 11 hours a day, 8 a.m. to 7 p.m., 7 days a week. And then you have IOP, intensive outpatient, which is 4 to 5 hours a day, 3 to 4 hours a day, 3 to 5 days a week. So that's something people can come to after school, after work, that sort of thing. And then you have just straight outpatient. So kind of depending on the severity of where they fall, will let you know where they need to be at what level of care. If they are not able to follow a meal plan on their own, they need to be in a higher level of care. If they cannot do it, just, the dietitian hands it to them and you give them, I would say, a month tops to figure out if they can do it and stop their symptoms and follow that meal plan. And if they can't, then they need more structure and they need a higher level of care. So that's kind of a good rule of thumb when you look at when to refer out. So what do we know? What works for eating disorders? We know that CBT is actually, CBT works for almost everything, right? Eating disorders are one of those. And so we know that it actually helps. There's a lot of distorted thoughts that come with eating disorders. The essence of them says that I'm the exception and not the rule. So other people can do these things. Other people have to eat. Other people have to what have you. I don't. I can't. I'm not allowed to do that. So working on those distorted thought patterns, no matter what kind of therapy you do, is probably huge. And so CBT is good for that. We know that interpersonal therapy has been found to be just as good as CBT for bulimia, but it takes a little bit longer. And then, of course, antidepressants, but they need to be in therapy too, right? And a lot of psychoeducation can be helpful, especially with the family, because families just don't understand eating disorders. Families all the time will say, why can't you just eat? Just do it, right? The Nike mentality, just do it. But it's obviously so much harder than that. So if you can give the families some psychoed to increase their buy-in, to keep the patient in therapy, then we're doing great. That's a key piece. Typically, the patients know more about the consequences of eating disorders than you ever will, and they've researched all this. They're smart people, and so the whole death speech for them isn't really going to be very beneficial. They know the consequences. They know what they're doing. They just don't care, right? It's the same way if you think about it with substance use. Everybody knows that cocaine isn't good for you, but it's the draw of the drug, right, that's more powerful than the consequences. So the exact same thing. So you need to educate the family to let them be your buy-in for the consequences. Let's see. So that's CBT. Family-based treatment is really what we know is the premier thing that works for those 18 and under. And that's when you're including the parents, you're including the family, and you're teaching them how to feed their child. So, for example, anybody ever heard of the Maudsley Method? Have you all heard of that? The Maudsley Method, Maudsley started family-based treatment in the UK, and now there's, some different kind of variations of it, but all of it really comes back to eating dinner with the therapist. With the family eats dinner with the therapist in the room. The therapist usually doesn't eat, sorry y'all. And so, but the therapist watches and coaches and helps the family really stay on the child and say, look, you need to eat one more bite. Can you just eat one more bite? And that's the essence of this work, is getting them to do one more bite. Maudsley, or family-based therapy, it starts with what we call the death session. And this is where you bring the whole family in and you sit them down and you explain to them with the child in the room, siblings, everybody, that this person is going to die. They are on a death track. And you do that psychoeducation piece that I was just talking about. And it's not exactly a scare tactic, but it sort of is. But it's an education tactic because, as I just said, right, this is the most deadly mental illness for those 18 to 24. And so we know that really if they don't get cured in some way, then that is the ultimate end of an eating disorder. And so we need to educate the family about that this is not just, hey, my kid isn't eating, this is a big deal and they got to take it seriously. And then after that, you start training them how to feed their child. And you explain, hey, just like your child couldn't feed themselves when they were 3 years old and you had to be in charge of it, you were the one saying, okay, one more bite of peas or, whatever. Your child has a disorder right now and they're not able to feed themselves. They're not able to think like a 14-year-old, a 16-year-old, a 12-year-old, whatever, about their food. So you have to take over and do that. All of the benefits show even after 5 years, this is really, it's the retraining of the family is what works for those young ones. Because no 12-year-old fixes their own dinner as a general rule, right? Little snacks here and there or whatever, but it's up to the family anyways. So you're starting ground level, getting those involved that are most involved, that should be involved naturally.